Hi rabbits, Research Turtle here. Welcome back to the CVRM Mastery Series. Today we are diving deep into what I call the synergy of survival. We are looking at the powerful combination of Empagliflozin and Incretin therapies, specifically GLP-1 receptor agonists. If you look at the history of diabetes treatment, we used to be obsessed with numbers. It was a glucocentric world. Treat the sugar, drop the HbA1c. But as we see in the CKM syndrome diagram, that's the old standard. The new standard for 2025 isn't just about correcting numbers, it's about organ protection. We're treating a continuum that links the heart, the kidneys, and the metabolic system. Let's break down the mechanics, starting with Empagliflozin. Think of this as a hemodynamic reset. In the kidney, diabetes causes high pressure, hyperfiltration. Empagliflozin restores the feedback loop to the macula densa, constricting the afferent arteriole. This drops that internal pressure, physically protecting the delicate filters of the kidney. But the magic also happens in the heart. We call this the fuel shift. Failing hearts struggle to use glucose. Empagliflozin promotes the production of ketones, specifically beta-hydroxybutyrate. This acts as a superfuel, giving the heart more energy per unit of oxygen. Now, let's bring in its partner, the GLP-1 receptor agonist. If Empagliflozin is the mechanic, GLP-1 is the vascular remodeler. It targets the root cause of atherosclerosis. It calms inflammation, converting angry M1 macrophages into peaceful M2 ones. It stabilizes plaque by thickening the fibrous cap, preventing those dangerous ruptures that cause heart attacks. Here's where the magic happens. We call this protecting the pump and the pipes. Empagliflozin handles the pump, the heart failure aspect, by reducing hemodynamic load. GLP-1 handles the pipes, the arteries, by fighting atherosclerosis and inflammation. When you put them together, you get complementary coverage. It's a classic case where 1 + 1 is greater than 2. There's a metabolic bonus too. We know SGLT2 inhibitors cause you to lose calories through urine, but that often triggers a compensatory appetite. You get hungry and weight loss stalls. GLP-1 fixes this. It suppresses that appetite. The result? You break through the plateau and achieve sustained additive weight loss. Does the data back this up? Absolutely. Look at the Duration 8 trial. Over 104 weeks, the combination therapy didn't just win, it dominated. We saw superior HbA1c reduction and superior weight loss compared to either drug alone. But it's not just about labs, it's about hard outcomes. Meta-analyses show a 41% risk reduction in major adverse cardiovascular events, or MACE, and a massive 55% reduction in heart failure hospitalizations compared to monotherapy. For my rabbits in Korea, this is especially relevant. We often see the sarcopenic obesity phenotype, lower BMI but high visceral fat and weaker beta cell function. The 2025 guidelines reflect this person-first approach. If a patient has high risk factors like heart failure or CKD, we don't wait for metformin to fail. We start these organ protective drugs immediately. If HbA1c is high at diagnosis, we consider this combination right out of the gate. However, we must be careful. We have to talk about safety, specifically euglycemic ketoacidosis. SGLT2 inhibitors increase ketones. GLP-1s reduce appetite. If a patient gets sick and stops eating, this creates a perfect storm for ketoacidosis even with normal blood sugar. The protocol is clear. Teach the sick day rules. If you're vomiting or can't eat, stop the SGLT2 inhibitor immediately. Hydration is key. To wrap up, this combination is not just an upgrade, it's a life-saving strategy. We're moving from simply managing sugar to actively preserving the heart and kidneys. It's the future of CKM management. That's it for today. Turtle out.